Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast. I'm Dr. Joe Tatta. It's a pleasure to be spending this time with you. On today's episode, we're discussing pain processing in autism and ways to improve pain management for people where pain communication could potentially impact care. My guests this week are Bethany Donaghy and Dr. Michelle Failla. Bethany is an autistic PhD student at the Liverpool John Moores University in the United Kingdom, studying under the Pro-Vice Chancellor Scholarship Award. Her current PhD project and work explores pain in autistic children. Bethany has completed both a bachelor's in applied psychology and a master's in brain and behavior at Liverpool John Moores University. Dr. Michelle Failla is a research assistant professor in the College of Nursing at The Ohio State University. Her research focuses on understanding the role of social communication in pain responses and pain management. She is particularly interested in studying pain populations with differences in social communication across the lifespan from autism to Alzheimer's disease. On today's episode, we take care to answer the questions: why do people think autistic people feel less pain? What is the history of understanding pain in autistic people? What do we know about pain in autistic children? Do autistic people process pain differently? Do autistic people express pain differently? And the consequences of not adequately assessing or managing pain for autistic people. As many of you know, one of the central aims or the mission of the Healing Pain Podcast is to raise awareness around the safe and effective treatment of both acute pain and chronic pain for individuals and certain populations. Oftentimes, I do that at the end of a podcast, where I ask you to share this information with your colleagues or a friend or family member who may be impacted by the topic we're talking about during the week. Today, I'm going to do something a little bit different. I'm going to ask you to share this episode at the beginning. The reason why is because this affects the development of many children. And we know that pain and the processing of pain happens in early life. When pain is not adequately treated or managed in early life, oftentimes it primes the brain and the nervous system to create or generate pain more easily in later life. This is one of the central reasons why I wanted to have Bethany and Michelle on the Healing Pain Podcast to share their work and their unique perspective. Many people, including practitioners, are still unaware of this topic. I know I can speak for Bethany and Michelle and say they'd appreciate you sharing this episode on your favorite social media handle. Okay, without further ado, let's begin and let's meet Bethany and Michelle and learn about pain processing and autism. Hey there, Michelle. Hey there, Bethany. Welcome. I'm excited to have you here this week.
Hi, thanks for having us.
Yeah, hi, it's nice to be here.
Thanks for joining me. This is an important topic that we have not covered before on the evolution of this podcast, and we're trying to give a little bit more attention to children and adolescents because in the literature with regard to pain, it's still a relatively new area. And I think a good place for us to start is just to let our listeners and our viewers of the podcast know how you became interested in the topic of pain management, where communication might be challenging for an individual.
Yeah, so, I think what brought me to study and think about how we talk about pain for individuals who have different communication styles was really talking to autistic adults and children who really gave us their experiences on how pain is different for them, how they maybe didn't always necessarily feel listened to in clinical encounters. And it got me really thinking about how most of our, measures of pain, most of the things we talk about with pain are so specific communication styles. And even the tools that we use to understand pain outside of, normally you walk into the doctor's office, you're getting that question of what's your pain on a scale of 1 to 10. Even outside of that, for people who might have different communication styles, we're looking at their facial expressions, we're looking at their body posture, we're just trying to read them. And it just got me thinking about how how really disadvantaged often people are if they have a different style of communicating their pain, and how that's going to just impact and compound the situation. When you're in severe pain, you're awfully, really stressed out. You're coming in with this immediate need, and being able to accurately and quickly assess that is so important, both for the individual and the clinician. And so, really just talking to people who are going through that and thinking about my own experiences of how I want to communicate pain so quickly. And so just thinking about how that would be different for so many different populations, depending on how they communicate.
Yeah, I think for me, again, just echoing what Michelle said about this communication style and things, there is such a massive health inequality for autistic people. And I think it's something that needs to be addressed directly. So to be part of that conversation and help, turn the tides with that, to make healthcare as accessible and inclusive as possible. But even, with lived experience, I'm an autistic person myself, and I know how difficult it can be to have, my experiences of pain understood by others. And even on the flip side, how I understand other people's pain. So I grew up in a household where my mum has chronic pain, and there'd often be times where my mum would be expressing the typical, really heightened pain expressions. So like crying, or she'd be, rolling around because she was physically in that much pain. And it was hard for me to even recognize and process she was in pain. So I suppose it's an understanding of autistic people's experiences themselves and how autistic people perhaps process such pain in others.
I love that the two of you are really approaching it from kind of this multidisciplinary approach where obviously there's, you're both researchers. Michelle, you've finished your PhD. Bethany, you're in the middle of your PhD, but you're also bringing the lived experience in, which is so important for people because obviously when we're dealing with conditions where communication can be challenging, that sounds like it's a big part of where all this research is kind of building and heading is, okay, if we can't communicate effectively with someone, how do we change? What do we have to do? Can you give us like a little bit of the backstory of how we've so far have addressed pain in the autism population kind of in the past before we talk about obviously your research and discoveries?
Yeah, so it's, you can look back at even the earliest descriptions of autism, and there's these descriptions of differences in reactions to pain. There's all these sort of really salient examples of, the child being able to play outside in the snow and not really experiencing sort of the pain of being in the snow for a long time without gloves, or things like that. And so there's very clearly, even early on, there's some different sensory experiences. And I think those are, become really recognized a lot more in autism. But pain is one of those things, I think, that unfortunately, there's just been this really long history of this assumption that autistic people don't experience pain as much or are less sensitive to it. And, a couple of those things come from these early descriptions. And then also, I think the fact that so many individuals engage in self-injurious behaviors. And so things like headbanging or skin picking to the point of opening wounds led to this sort of assumption for decades that autistic people must be insensitive or much less sensitive to pain. Mm-hmm. And so I think there's the really, as Bethany mentioned, like this really long history of really since we started talking about autism and diagnosing autism, that you're sort of at this biased situation of assuming that people are not experiencing pain as much.
Yeah, and I think something that's always coming up is people's, misconceptions from, anecdotal perspectives. So a lot of the times, even in conversation with people that I have now, they will use the past experience with one autistic person and they will apply that to every autistic person. And, we know pain's so subjective. So why do we presume that in a certain population, subjectivity doesn't exist?
Yeah, I mean, we can obviously look at populations of people which is what we do in research, and we gather some good data from there. But whenever we work with someone with pain, we always approach them as an individual, right? And autism or the condition of autism shouldn't preclude us from approaching people in that way. So really what you're saying, and this is I think this is really new, is that autism can be a risk factor for the development of chronic pain in children and adolescents.
Yeah, that's something that we are, I think, in the last 5 years, just really taking stock of that, and really is a very new idea. But that's exactly where I think we're all seeing this, that not only from the aspect of you've got communication issues that might preclude them from getting the management that they need. So then you're at risk from just having, consistent chronic pain in that way that it's not managed well. And then you have all these other co-occurring medical conditions, which may be layered on to that communication problem, which may be genetic. There's lots of evidence of co-occurring epilepsy and things like that just tend to be you see more of in autism. And then I think just sort of there's a lot of work coming out now of just and I think, Bethany, you can probably speak to this more of just the experience of having to sort of live in a neurotypical world and having to manage your own psychosocial stressors and things like that. So then you've got miscommunications, mismanagement of pain, extra stressors, extra medical conditions. So exactly, you're left with this really, constellation of reasons that they might be, people might be at more risk for chronic pain.
Yeah, definitely. And to build on what Michelle said, a lot of people still see autism as, a person who doesn't like noise, they don't like light, and people tend to really hone in on that. And, going to the hospital and things, there's so many different noises, there's so many different smells, there's so many different lights, and the lighting's quite harsh that it makes that such a difficult experience. So then to go in and speak to someone you don't know about something that neurotypical people struggle with, putting words to what they're feeling, it can be really difficult. And a lot of people may just avoid that altogether because it's, in their eyes, stress that's not needed, which, as we know, with how chronic pain can develop and things, is quite a concern.
So I want to take some time, because I know both of you have done some research. I want to dig a little bit down into some of the discoveries that you've made. And I've read a lot of your papers. They're great. We can link to them and point people to them if they're researchers or educators who are interested. But you mentioned sensory processing, which is commonly mentioned with autism and the autism spectrum. But how does that start to connect, or what are the discoveries that you've made between sensory processing and pain processing?
Yes. So, I think pain is sort of the last modality, or maybe not the last modality, but we focused a lot, like as Bethany mentioned, like thinking about sound and aversion to sounds and aversion to visual stimuli that is very complicated. We've talked a lot about those sorts of sensitivities, and even in sort of diagnostic criteria, we talk about, like, does the child respond to their name? Are they bothered by different textures? Things like that. So, pain is mentioned in diagnostic criteria as an example of, particularly if they're insensitive to pain. So again, sort of perpetuating what we talked about earlier, that autistic people might be insensitive to pain. But what we actually really don't know is, with people who autistic people who are either really sensitive to pain or much less sensitive to pain, we don't know what the sort of full spectrum looks like, that even across all these individuals, just as pain is such an individual experience, there's likely some people, and we've seen them in our research studies, that are really hyposensitive to pain. I can go through all these pain studies and they are never telling me they're in pain. And then other people who cannot participate because even the really low level stimuli are just sort of too much and too painful for them. So it's definitely a wide berth. But what we don't know is how that maps onto different sensory sensitivities. So we don't know if the people who are really sensitive to pain are also really sensitive to light, to noise. That's work that we're still doing. And we're trying to understand if that within the same person, is that just sort of a general sensitivity to all these different sensory experiences, or is it specific to pain, for example? Yeah, so we're still working on.
Right, because the nociceptor itself, which processes noxious stimulation, is not just what people think of as pain, but obviously there's heat, there's cold, there's pinprick, there's vibration there's actually itch now being connected to pain.
Yeah.
There's so many different levels of, as you mentioned, that processing with pain. So we're talking about sensation. Oftentimes we're talking about not only kind of the sensory motor aspect of a condition, but also autonomic processing, which becomes part of that entire experience. And then moving up, of course, into the brain, we know that in most people, there's a pain neurosignature, or we might call it a neurotag of some sort that's common in people. Do we see the same neurosignature in people with autism?
Yeah, so the work that we've done was looking at how autistic adults particularly respond to heat pain. So we can, give this, it's a small thermode that we can put on the leg and heats up to different temperatures. And we can heat that up to just sort of a very mild pain experience. And when, in most people, we'll see, the neural pain signature is responding pretty robustly the whole time they're in pain. And that includes, somatosensory regions, affective regions, and really is a, nice robust signal across this whole network of brain regions. In autism, when we did this, we looked at a stimulus that was about 20 seconds long, and we see that whole signature response for the first 6 seconds. But then while they're still experiencing that pain, that whole signature is just diminished. So even though the person is still telling me they're experiencing pain, the brain response is gone away. And that was honestly pretty shocking for us to see, because it doesn't match what the experience is. The person's still saying that was painful till the end, but the brain response is gone. So we are, we did this work because, we know that they're experiencing pain differently, but we don't know why. We're looking for these mechanisms or trying to understand how to map on the lived experience to the neural responses, and they don't match. So that's one of the most interesting things that we've seen lately.
I mean, I think that's so important because some of those studies, when you read some of the studies, like we have a clear signature of what pain looks like in the brain. And then you read some other studies and they say, well, these are really snapshots in time of a human experience, so to speak. And that might change over the course of minutes, hours, days, weeks, months, et cetera. And a lot of your research clearly pinpoints that in the autism spectrum, but it also might extend and now say, hey, maybe what we thought was a pain neurosignature in humans, maybe there's something else that happens once we take them out of the functional MRI machine, which I think is so important, right?
Yeah. And that's one of the things about the reception of that work has been that, I see a number of people now asking me, well, what if we look at Alzheimer's disease or other, disorders where we see really different pain responses? Would we see something similar? Or, the brain, we expect something correlates with the experience that we're having. That's sort of a basic principle. And so how we're measuring it maybe is maybe not right, or isn't giving us the information we need in the autism population. And so to me, it's just a big clue that we need to look harder and understand more of what's going on in the brain while people are experiencing pain.
Anything you'd like to add to that, Bethany?
So at current, my research particularly haven't necessarily looked more at, like the neuroscientific aspect of it. what we found is more communicative based, and how pain as an experience can shape how, the child tells people, who they tell, how these social factors come into play in this pain experience to shape their particular intensity. So something we found, moving away from the kind of neurosignature, that is particularly important from a social aspect is who the individual is with. So from the interviews we've just done, we found that a lot of the children would be in pain at school, but unless there was a figure there that they particularly trusted and was close to, so for example, a special educational needs teacher who was with them consistently throughout the day, these children would go and just not tell anyone at all until they got home. So if that teacher, that trusted figure, wasn't accessible, the pain just would not be reported. No one would know.
It's interesting to think about how the neuroimaging, because people take those images and they say, okay, well, the prefrontal cortex is lighting up, so we have to design an intervention that targets the prefrontal cortex. But then you find that, well, that neurosignature is not consistent in this population, right? And then you try to map that onto what the behavior is, which is really what Bethany is talking about, right? So, well, here's how these individuals are responding in real life situations, or how they're not potentially responding in real life situations. And it's interesting because so much of the data that we have on pain, I think, revolves around chronic low back pain.
Right.
And this is just such a different population. And, my mind is just kind of turning over right now, thinking about all the various applications where a lot of practitioners, and some researchers think they have a clear idea of what pain is. When I think a good part of your message really is we're just on the cusp of really learning what's happening in the body and how various different individuals respond in their environment when they come across a context that they're suffering in.
Well, and it's a very interesting point that you bring up, because, in a lot of other sensory modalities, vision, hearing, we feel very, I'd say, a lot more confident that we can measure sort of pure sensory responses. Whereas in pain, it's always overlaid with the sort of emotional, psychosocial aspect. And I think that's, as a field, I think in pain research, we've done a very good job of thinking about it in that terms, but it also is a complication in how we measure things, because, even when it comes down to when we measure pain thresholds in autism, we've seen that, because of psychomotor slowing and things that we, imagine are sort of more common for autistic people, that when we do these reaction time based pain thresholds, just press this button when it becomes painful, that's going to be different in this population and biased, and actually suggest that they don't have differences in pain thresholds. But when we do it a different way, where we're just giving these stimuli and sort of rating them, and, going back down to when it's just warmth, going back up to when it's pain, and trying to find that temperature when it's consistently painful, then we do see that pain thresholds tend to be more different and lower in autistic individuals, which flies in the face of everything that we had this sort of historical bias that people would be insensitive. But this kind of work really has also, I definitely went through a period when I first started doing this work where, what do we really know about pain, especially because autistic adults, especially when they'd come into the study, would say, well, I'd say, push this button when you're in pain. And they're like, well, what do you mean by pain? What does that really mean?
Wow.
Yeah. And it's one of those things like you don't think about. You're just like, well, are you in pain? That's not an easy question when you have to define it. And Bethany, I know when you talked with especially autistic children, like trying to explain that and have those conversations about what does pain mean to you becomes even more complicated, I think.
Yeah, definitely. And it's So it's so important to use things like, you know, PPI panels, so hearing the voice of people in the public who are autistic, and not just, you know, autistic children, autistic adults as well. Every autistic adult was once an autistic child, so getting that perspective is important. And, you know, advocacy in the autistic population is absolutely huge. So even hearing from the parents how they, you know, perceive their child to describe pain, explain pain, what pain is to them, essentially. I think it's so important to get that voice heard and, you know, acknowledge it, to make the methods that we use in assessing and researching pain, treating pain, as inclusive and accessible as we can. Something that we've done recently for an upcoming study is how Michelle was saying about, you know, like pressing a button when pain was perceived, getting that reaction time based data. We've used a sign that the children can put up, which will say now. So when the perception of pain is there, they can just show a sign instead of having to verbalize, because as we know, in the autistic population, there's differing verbal, you know, abilities. Some children are verbal, some non-verbal. So really still trying to get that data in a way as inclusive and accessibly as we possibly can.
It's interesting. So Bethany, you mentioned explain pain. You said the words explain pain, and there's a whole cognitive theory called explain pain, or a cognitive approach called explain pain, where you help explain pain to the individual and the neuroscience behind it. We try to simplify it. And it just makes me think how, as far as that work has come, a lot of the work that you're doing, Bethany, you could really springboard off that and figure out, okay, how do we now apply this to autism? And then how do we apply this to maybe those that are hyposensitive to pain in that population, and then hypersensitive to pain, because we have both in there. And it's important to educate both about pain, but in a really different way. How is the autism, what's the feedback been from the autism community around this topic and some of the research findings that you have here?
So for the research I've done so far has been quite positive, to be honest. We've had some really great feedback whereby parents have actually expressed to us they've heard the children say things about the pain that they've never heard themselves, which is absolutely massive. You know, the implications that can have in that child's journey now with pain management is huge. And I think some of the things that have allowed for that important communication is making an environment where the child feels safe and they have the time to think over what they're actually going to respond with. And I think being open as well with the fact that I'm autistic. So there's a lot of research around how autistic people communicate with one another compared to how an autistic and allistic people communicate with one another. So having that open communication, you know, I'm autistic, I understand what you're going through, I've been judged in ways that is probably similar to how you've been judged, has just made an environment, again, that's trusting and really facilitates that conversation, which has been really positive.
Yeah, and when you say providing them with the space to respond, really what you're saying is, in the average person, if I take a pin, let's say, and stick them in the finger with it or prick them with a pin, they're going to feel that pretty fast. And there'll be some kind of either physical mannerism, verbal response that happens. But potentially with someone in autism, that is processed much slower. And it might not be the type of typical behavioral reaction that you're used to seeing in someone who is not autistic.
Yeah. So, yeah, essentially that, and given the time for them to actually process what they're feeling, the words they're going to use to, you know, attribute that feeling to.
I mean, time is such, I just think, sorry, I just want to touch on time for a minute, because in our busy healthcare and our busy lives in general, people with pain deserve a little more time. And that's not just people who are autistic, but the whole spectrum of chronic pain. It takes more time to evaluate. It takes more time to assess. It takes more time to develop a relationship. It takes more time to learn that particular person's history and how their history impacts their current perception of pain. And I think that the point of giving, you know, particularly children and adolescents with autism more time is important, because that's when their nervous system is being shaped, right? Before they enter into adulthood.
Well, and that's something that we've heard from we've done some interviews with autistic adults where we've asked them, what was your pain experience like? When did you first recognize that you might have a different response than others? How has that shifted and changed as you've grown up? And time again, we heard stories of, my mom, I dropped something on my toe and I didn't have a reaction. And just that recognition, that moment of that their parent or caregiver was like, I can't believe you don't have a reaction to this. That should be painful. And then that recognition of like, oh, it is painful. I just didn't necessarily feel the need to do anything about it, or didn't need to, so like just and having people sort of walk through and talk through these different experiences like that, like you said, being able to have the time to understand that maybe what, that there's this change in how they've decided to express their pain, as Bethany mentioned, like, in talking with people in Bethany's study, as she mentioned, like that now they can express pain in different ways. That is also something that we keep sort of hearing about, is like this just recognition that their experience is different actually allows them to then have different words to use for it, or different descriptions, or just the empowerment to say that this is a very different experience for me, and there is evidence to suggest it is. And it's not just me sort of saying it, it's backed by science now, so I think that's the reception that we continue to get, and that understanding how that shifts and change across development, I think, is really crucial, like you said, so that autistic children and adolescents now can recognize that now and don't go through the same thing we're talking to autistic adults about, and how they have been suppressing pain for so many years.
There's a significant amount of talk with regard to early life experiences, specifically trauma, in people with chronic pain. And I'm wondering how you'd like to see this work be adopted by, obviously, parents and caregivers, but more importantly, I really think health professionals, not necessarily the ones working in pain, although we need this information, but I just think about going to the dentist. Right? Which is a pretty uncomfortable situation for most of us. But most dentists are not really familiar with the autism spectrum, so to speak. So how would you like to see this information really inform the care of people with autism, so that they don't undo medical traumas at a young age that might sensitize their nervous system for later on in life?
Yeah, I mean, so dentistry is actually kind of what spawned this for me, was that I was working with a dentist who was doing some research in pain, and they started thinking about this specifically and wondering if the brain response was different. That's really how this started, and so I keep coming back to it, actually talking to dentists about and actually at Ohio State, where I am, that we have a wonderful dentistry clinic that works with developmental disorders specifically. And it's been amazing to work with them, talk with them about ways that you can implement what we're doing. And we're looking to try to actually, do some of that work, because like you said, that's, I think, one of those places that we could have a big impact. But I think, Bethany, I think this is something you even think about more than I do, about how we could kind of, where we'd like to see this go early on in the lifespan.
Yeah, definitely. I think something that I think is so important is shaping the way healthcare professionals are taught, because I think, I don't want to say healthcare professionals are stuck in the ways, but they're educated to a certain standard, which is based upon a neurotypical communication, neurotypical expression. Yeah. And I think we need to reshape that to include what we know about autistic people's experience of pain, including, different intensities, different actual verbalizing, different pain behaviors, all these little things that we take for granted in the pain experience, to get it taught at the root of where this pain management actually stems from, I think is absolutely key.
Yeah, there's so much nuance in this experience, in this population. Bethany and Michelle, I want to thank you for being here, and thank you for your work. I know that, of course, people with autism and their families will appreciate this, but pediatric OTs and PTs and mental health providers will be really interested in this work too. And they're going to want to follow you because I know you're constantly working on this. So let them know how they can learn more about you and follow you.
Yeah, you can find me on Twitter for sure at Failla PhD. And then, we've got on the Ohio State website, there's, information there on my faculty page as well.
Yeah, the best way to find me is definitely on Twitter. My Twitter handle is Bethany Donaghy 1. And you can also find me on the Liverpool John Moores University site if you just type in my name.
Great. So once again, I want to thank Michelle and Bethany for joining us this week on the Healing Pain podcast. Make sure to share this information with your friends and family on social media. That would be Facebook, LinkedIn, Twitter, Instagram, anywhere that people are talking about chronic pain and autism. I'm Dr. Joe Tatta. Thanks for being here, and we'll see you next week.
Thank you.
Thank you for listening to the Healing Pain podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.